Thank you so much for having me. And this is my first time giving one of the core teaching conferences by Zoom. So hopefully it will go well. And please, I think we'll have someone monitoring the chat. If people have questions or comments, can type there. And I'm also happy to have people interrupt for verbal questions during the presentation. So I'm a nephrologist. That's certainly my first caveat, but am a hypertension specialist and run the Hypertension Clinic at Harborview, which is a UW-wide resource for our patients, your patients, and others. And so please feel free to use me in the future as a resource, even for informal questions by email or page. So no disclosures. So this is our objectives for today, a little bit of an overview. So we are going to discuss, to some degree, a review of the physiology of blood pressure regulation, not to recapitulate medical school, but just because I think it helps focus discussion around some secondary causes of hypertension to consider, and also because it provides insight into how our antihypertensive agents work. We'll talk about the rationale for blood pressure control among patients with hypertension. We'll discuss current clinical practice guidelines around the measurement of blood pressure, what blood pressures we should be targeting in our patients, and a management strategy. And then we'll discuss some elements of the indications and steps for workup of secondary hypertension. So I wanted to use a case to sort of focus the discussion today. This is a case from a couple of years ago now. That I saw at the Hypertension Clinic. This is the case of Dr. W. So he is a 66-year-old retired vascular surgeon, and he actually self-referred to me with a 2-year history of hypertension, really worsening relatively quickly over that period, with blood pressures now in the 170s to 180s systolic. He was on sort of an increasing intensity of antihypertensive medication regimen. At the time I saw him was on amlodipine 5 milligrams daily, had metoprolol added, and valsartan titrated up to 320 milligrams daily, which is the maximum dose. And then it had recent addition of hydrochlorothiazide, clonidine, and finally doxazosin. So really scraping the bottom of the barrel for blood pressure agents here. He did drink alcohol, 1 to 2 drinks daily. So in terms of his past medical history, has a history of coronary disease, had a 5-vessel bypass surgery now about 20 years ago, has known peripheral vascular disease and carotid artery disease, had a carotid endarterectomy in 2008. Did not have diabetes, but some perhaps impaired glucose tolerance. When I saw him, his exam was really normal, other than elevated blood pressure at 160/95. And then his labs are, as you can see, so his potassium was 3.4. He had a serum bicarbonate of 30. His creatinine was elevated at 1.4. And he had no albuminuria. So, just to focus our discussion today, these were the questions that were running through my mind, and I hope to kind of go through them with you guys today as an overview of hypertension. So the first question is, why should we care about his hypertension? We'll then talk about, potential causes of hypertension in this patient. We'll cover what his target blood pressure should be, or at least what I think it should be. What workup should he have for his hypertension, if any? And then what should his optimal blood pressure regimen be in terms of medications and non-pharmacologic therapy? So first, why do we care about his hypertension at all, right? And so, I think just stepping way back, what is hypertension? What's the definition? And I think the classical thinking was that hypertension is equal to elevated blood pressure. Now, I think this has been challenged in more contemporary thinking, which is that at least primary hypertension, which we'll cover in a few moments, is really a progressive cardiovascular syndrome, right? It's caused by a variety of different factors, interrelated. And in fact, some features of this syndrome may actually be present before the blood pressure elevation is sustained. So blood pressure is really a biomarker of this clinical syndrome of hypertension. Okay? And we'll cover how progression is associated with functional and structural abnormalities of many end organs. But certainly that being said, though hypertension is a systemic cardiovascular syndrome, there really is no diagnostic test or assay at this point other than measurement of blood pressure. So that's what we're going to focus on going forward. And what I've shown here in this slide is what I would consider the current diagnostic criteria for normal, elevated blood pressure, and then the 2 stages of hypertension. And this comes from the, I would say, most recent and pertinent clinical practice guidelines, which we'll cover frequently today. So, this categorization would consider a blood pressure normal only if under 120/80. What previously was referred to as sort of pre-hypertension is now called elevated blood pressure. I think that's semantics, really not terribly important. But anyone with a blood pressure of between 120 and 129 systolic, still with a diastolic of less than 80, would be considered to have elevated blood pressure. And then any blood pressure above those ranges is hypertension, with stage 1 hypertension being a systolic of 130 to 139 and a diastolic of 80 to 89, and anyone above that having stage 2 hypertension. We're going to cover measurement of blood pressure a little bit later, but just as a reminder, blood pressure or hypertension should never be diagnosed in a single clinical visit with a single blood pressure, right? So this should be based on the average of greater than or equal to 2 readings obtained on at least 2 occasions or more. And this is the clinical practice guideline, that we're going to cover in some detail today. We'll get back to this, but this guideline was published now a little over 2 years ago, and it is called, some people refer to it as the ACC-AHA hypertension guideline, and that's how I'll refer to it today. But it comes from primarily the American College of Cardiology and American Heart Association, although many different organizations signed on to this guideline. And it really remains the prevailing clinical practice guideline in the United States that comments on and provides treatment recommendations for patients with hypertension. An important point to at least dwell on briefly is that these 2017 guidelines really represented a true paradigm shift in both the definition of hypertension and in the treatment targets for antihypertensive therapy for people with already diagnosed hypertension. Prior to the release of the 2017 guidelines, hypertension was really universally defined as a blood pressure of greater than 140/90. And this really came from a clinical practice guideline published way back in 2003 that is known as the JNC7 guideline. So JNC stands for the Joint National Committee on the Prevention, Detection, and Evaluation and Treatment of High Blood Pressure. And it was really the last clinical practice guideline on hypertension that had financial support and endorsement by the NIH. And there was, many people say, well, what about JNC8? If people remember, this was a couple of papers published in 2014 in JAMA that was published by a number of members of what was going to be the 8th Joint National Committee report. But in the middle of preparing this report, the NIH decided they didn't want to be in the guideline business anymore, and they basically withdrew their endorsement. So what has been called the JNC8 guideline, again from about 6 years ago now, did not have widespread support, was not implemented widely in clinical practice. But the important thing to remember about it is that the threshold was 140/90, just like JNC7 for most patients. And in fact, for some patients who are older than age 60, it recommended an even higher threshold of 150/90. And that higher threshold of 150/90 made a lot of people uncomfortable and therefore didn't achieve widespread recognition and adoption. So the changes from JNC7 to this most recent 2017 ACC-AHA guideline may seem small, right? It's just a target of 130 over 80 from 140 over 90. It seems small, but I think this figure here illustrates the profound impact that it really had on the percentage and numbers of US adults diagnosed with hypertension and for whom blood pressure was considered uncontrolled. So in this left panel here, this is the proportion of all US adults that would be considered to have hypertension. The red bar, that 32% of all individuals, would be what the prior guidelines would call hypertension, so the JNC7 guidelines. An additional 14% of patients now with the most recent guidelines in 2017 now have hypertension, which if you skip over to the right-hand series of bars, shows that 103 million people in the US now have hypertension according to these most recent guidelines. Right? As importantly, the newer guidelines sort of overnight increased rather dramatically the proportion of patients for whom blood pressure is now considered uncontrolled. So with the new 2017 guidelines, over 50% of patients with hypertension on medications now have uncontrolled blood pressure, up from less than 40% with the prior guidelines. So really profound implications in terms of our care for patients, how closely we need to be monitoring and how aggressively we need to be treating patients. Okay, so I've told you that hypertension is common and perhaps increasingly common in light of new diagnostic criteria, but why do we care about it so much? Well, I think the first point is that as a systemic cardiovascular disease, the presence and control of hypertension impacts a large number of end organ systems that we all care about. So this, of course, includes the brain, with earlier symptomatic lesions perhaps just being hypertensive retinopathy, more progressive lesions including vascular dementia, transient ischemic attacks, and strokes. Okay. The cardiovascular system, of course, so persistent hypertension causes left ventricular hypertrophy as sort of the preclinical lesion, followed by heart failure, various arrhythmias, and finally sort of end-stage congestive heart failure. And then, of course, my favorite organ, the kidney, hypertension is the second most common cause of dialysis dependence in the United States, with diabetes being the first, hypertension being the second. Okay, so all of these things, of course, and then increased risk of death, as well as non-death sort of comorbidity as well. And then furthermore, the association of blood pressure with cardiovascular outcomes is linear and profound, and I think really undisputable. So this is figures from this landmark study now from The Lancet. It was really a meta-analysis from now almost 20 years ago that looked at 1 million people with hypertension and looked at the association on the x-axis, in this case of systolic blood pressure, and on the y-axis with a variety of different cardiovascular outcomes. So the left panel here is stroke mortality. The right panel is ischemic heart disease mortality. And they've stratified things here by sort of age decile. And what you can see is no matter how old you are, the higher your blood pressure is this linear and dramatic increase of risk of whatever bad outcome you look at. Okay. Now, of course, that's observational data. But the other point is that we have evidence now from trial after trial after trial from decades of work that treating hypertension profoundly improves outcomes for our patients. So this slide just shows the results from 3 randomized studies across different decades with different agents. So the SHEP study, which is the blue bars, the systolic hypertension in the elderly study, used chlorothalidone. The CIST-UR trial in red used nitrendapine, right, a calcium channel blocker, and the HOPE trial used ramipril, an ACE inhibitor. And regardless of which agent you use, regardless of which outcome you look at, whether it's stroke, ischemic heart disease, heart failure, other types of cardiovascular disease, the risk reduction with treatment of hypertension is profound. Okay. So hopefully I've convinced you that we should care about Dr. W's hypertension at all. And so the next part of the talk is to talk about potential causes of hypertension. hypertension. But before I go in, any questions about the first part of the talk? Okay, well, I'll go in. Again, feel free to interrupt. So the next thing that's going through my mind when I see this patient after why I care at all is what are potential causes of hypertension in this patient, right? And I think the first decision point is to assess whether the patient's hypertension represents primary hypertension, which is what used to be called essential hypertension, right? Or whether this may be, in fact, some so-called secondary hypertensive etiology. So I've already talked a little bit about primary hypertension, right? It's a progressive cardiovascular syndrome that's characterized by high blood pressure. And the key is, by definition, there is no identifiable cause. There is no diagnostic assay. Okay. The other option is that the patient has secondary hypertension. And what do we mean by this? This just means that there is hypertension that is not primary. It's due to some identifiable underlying cause. The estimates for what proportion of all hypertensive patients fall into this category changes all the time, and it's difficult to get a true read on, but it probably is between 5 and 10% of all patients with hypertension, and up to 30% of patients with true resistant hypertension. And we're going to get a little bit back to that. But as an introduction to resistant hypertension, this is what most people would consider uncontrolled blood pressure in someone on 3 or more medications that are in some sort of rational combination, right? So not someone on 2 diuretics or 2 calcium channel blockers. So, turning first to primary hypertension, I did want to spend, again, just a few minutes going over the pathophysiology, again, because I think it helps us think about what's going on, how our medications work. So I like to think of the pathophysiology encompassing these sort of 3 main pathways. So the first in the middle here is inappropriately high sympathetic outflow from the brain that leads to large arterial stiffness, increased systemic vascular resistance, and inappropriately high cardiac output due to increased chronotropy, okay, and increased contractility as well. The second is inappropriately high renin release from the kidneys, which may at least in part be driven by the sympathetic outflow. And then the third major category is abnormal salt and water handling in the kidney. So first, just turning to the sympathetic nervous system. So, first, focusing on this very top arrow in blue here, which says parasympathetic nerve. So remember that that blood pressure is really sensed in the carotid baroreceptors, in the heart itself, and in the aortic arch, where there are baroreceptors. And signals from these baroreceptors would be transmitted back to the brain in this afferent pathway. In response to low blood pressure, which is really what is sensed here, efferent sympathetic signals get sent out from the central nervous system that affect a number of different pathways. So first you have here, due to impact on alpha receptors, you get systemic vasoconstriction. Beta-1 receptors trigger increased cardiac output and heart rate. And then there are separate specific sympathetic innervation of the kidneys themselves that lead to increased renin secretion, and probably through some additional pathways to increase sodium intake and reuptake as well. All of these are going to lead to higher blood pressure, right? And so therefore, if there's some defect in some of these pathways that lead to an exuberant or overactive sympathetic nervous system, you're going to achieve a pathophysiologic high blood pressure or hypertension. Okay, so the second pathway, and equally important, is the renin-angiotensin-aldosterone system. So the signal for renin release can either be sympathetic signals, like I've previously talked about, or can be from the kidney itself through signaling from what's called the juxtaglomerular apparatus, which really signals low blood pressure through decreased sodium delivery in the kidney. Okay? And this ends up leading to renin release. So renin is an enzyme, right, that converts angiotensinogen to angiotensin 1. Angiotensin 1 then gets converted to angiotensin 2 through the converting enzyme in the lungs. Angiotensin 2 both directly constricts blood vessels as well as leads to aldosterone release. And aldosterone leads to sodium retention in the kidney, volume increase in the body, and higher blood pressure. So just as in the prior slide, defects or exuberance of any aspect of the system can lead to a pathologically high blood pressure. And finally, of course, you're not going to get a talk from a nephrologist without some nephron somewhere, and this is your medicine today. So just as a reminder, the nephron is the major site of salt and water handling in the body. And since we discussed how salt excess and salt retention can lead to hypertension, defects or exuberance of any part of this process can also lead to hypertension. As a side note, an example of how important renal sodium handling is in blood pressure are a variety of very rare monogenic causes of hypertension, which are single gene mutations that cause typically increases in sodium retention that can cause profound hypertension at young ages, right? And the prototypical one, which I've talked to many of you about in prior conferences and in my hypertension clinic, is Little syndrome, which is an overactivity of the epithelial sodium channel in the collecting duct. We won't get into this esoteria today, but happy to talk offline about these. Okay, so back to Dr. W now. So what are potential causes of hypertension in this patient, right? And this is what was running through my head. So does this guy somehow have an abnormal sympathetic tone that's led to cardiac remodeling and vascular remodeling? Well, maybe it's his kidney function actually. So I talked about his creatinine's 1.3. That's not normal for this man. He's got obviously some chronic kidney disease underlying. Maybe that's led to abnormal salt and water handling, and that's the cause of his hypertension lately. Well, gosh, he has severe coronary disease. Is it possible that he's now also developed an atherosclerotic lesion in his renal arteries that has led to impaired renal perfusion and like a renal artery stenosis? Well, we also noticed that his potassium was a little on the low side. His bicarbonate was a little high. Maybe he's actually got some sort of high aldosterone state, either a primary hyperaldosteronism or a secondary hyperaldosteronism. What I'll say right off the bat is that common things being common, it's likely multifactorial, a complex interplay of a variety of these factors. And still, it's usually more likely than not, even in a patient with severe hypertension that is of recent onset, that we fail to find a single etiology. Okay, so I'm going to move on to the next section here, which is, well, what should his target blood pressure be? I think I mentioned it was 165/95, which I think we can all agree is abnormal. But the question is, what should we be targeting? Now, I don't think we have the poll function of Zoom working here, and I can't even really see the chat, so maybe I'll rely on our esteemed chief resident. If people could type in the chat what they believe the goal target blood pressure for this patient should be based on what I've told you. Is it less than 120/80? Is it less than 130/80? Less than 130/90? Less than 140/90? Or some other target? And Alana, maybe you could let me know what some of the answers are, what people, if there's some sort of consensus.
Happily. We have, there's a vote for D. There's also a vote for B. There's also a vote for C. So we do not have a consensus.
Okay. Just wait one more minute.
Yeah.
Any other votes?
I think the only one we haven't gotten a vote for is A and E.
Okay. No one for A, huh? Okay.
Not yet.
All right. So, I think the point is, as we saw there, you guys didn't have consensus. And I think the last decade of clinical practice guidelines in hypertension, cardiology, and nephrology would agree with you all. And I think this is why it's confusing, is just the sheer number of clinical practice guidelines can be overwhelming in this area. This is just a smattering. This is just since 2010. These are clinical practice guidelines worldwide from different countries, the European Society of Hypertension, the European Society of Cardiology, the American Society of Hypertension, right? This JNC8 guideline I talked to you about, the Australian guidelines, the American Diabetes Association, and then most recently ACC-AHA. Okay? I haven't even mentioned any kidney guidelines here. We'll talk about that in a little bit. And then if you look at the goals over here on the right, I mean, we've got everything from less than 120 to less than 130 over 80 to less than 150 over 90 in some cases. So this is challenging. But I think what I will focus everyone's attention on, and I think that we should, for the current time, for the most part, be adopting this clinical practice guideline as what we should be targeting in our patients for the most part. And you know, this has had really a profound impact, I think, on primary care, on cardiology, on internal medicine in terms of aggressive management of blood pressure, and is what I tend to follow in my clinic, with one exception. And I just wanted to present just a brief overview. Basically, the guideline is, 100 pages long, but let's try to get down to the core of what it is wanting us to do. Okay, so the first thing is for patients who have normal blood pressure, less than 120 over 80. Obviously, there's no indication for treatment here, but patients really should still be assessed annually, at least adults, for the development of higher blood pressure. And I agree with that. Right? For patients who have blood pressure of 120 over 129, 120 to 129 systolic, who still have a diastolic blood pressure of less than 80, I think this is a reasonable time to promote lifestyle habits, consider what they're calling non-pharmacologic therapies. That's really a promotion of healthy lifestyle in terms of diet, weight loss, and exercise. And I think that that's reasonable, and I think it's hard to really argue with that. They would promote here a reassessment of blood pressure even as soon as 3 to 6 months. That's pretty aggressive, but I think is something that we can consider. I think where things get a little complicated is in the stage 1 hypertension section here, where if you have a patient who has a blood pressure of 130 to 139 over 80 to 89, there's then the second step which is triggered here, which is an assessment of the patient's so-called ASCVD, or atherosclerotic cardiovascular disease risk. And it asks us to assess whether or not this risk is over 10% at 10 years. I'll show you the calculator in a moment, which I think most people are familiar with. If the risk is less than 10%, which is the minority of patients, you do not need to jump immediately to pharmacologic therapy. You can assess in 3 to 6 months and then kind of see where things go. If the risk is over 10%, which is the majority of patients, then there is indication to start one blood pressure agent and reassess quite soon, in 1 month, for whether the blood pressure goal is met. For anyone who has a blood pressure of over 140 over 90, they've automatically got stage 2 hypertension. Again, this is assuming that this measurement has been met with greater than 1 measurement and on greater than 1 occasion, ideally spaced at least a month apart. And there we can talk about whether or not one might actually start 2 medications at the same time. So this is the overall flow here. Okay. So let's focus on this CVD risk calculator. So you guys know that you can just go online. This is the website, but if you actually just search for ASCVD risk calculator, you're going to come to this website where you can plug in your patient's data, and it will tell you what their 10-year cardiovascular risk is. I'll tell you that the major influences here are age, right? Cholesterol is a big impact, and then the smoking history. And really, as patients get older, really above about age 40, it just it almost automatically gives you a 10-year risk of greater than 10%. So really, this is a big shift, these targets from previously. I've told you that, so why, right? And I think, I haven't talked much about individual studies, but I do think it is important to spend a moment or two on this study, which is called the SPRINT trial, or the Systolic Blood Pressure Intervention Trial, because it has had such a profound impact on clinical practice guidelines. So this was published now, seems like not that long ago, but 5 years ago in the New England Journal of Medicine. It is a multi-center randomized trial of over 9,000 patients. Critically, they were non-diabetic, and they had to be over 50 years of age, who were at elevated risk of cardiovascular events, right? And this was their criteria. You either had to have like a prior MI, have had prior ACS of some sort, a AAA of greater than 5 centimeters. You could have some subclinical cardiovascular disease, or a coronary artery calcium score, some sort of LVH detected on echo or ECG. You could have chronic kidney disease that would buy you elevated cardiovascular risk. GFR down to 20 was looked at. A Framingham risk score of over 15%, or just be older than 75 years of age. Patients were randomized to a systolic blood pressure target of less than 120, or what they called sort of a standard target of like less than 140, right? Their primary outcome was a composite outcome of basically a variety of cardiovascular events or death from any cardiovascular cause, right? The trial was stopped early after about 3 years, right? Not for a null effect, which is usually why trials are stopped early these days, but actually for a dramatic improvement in the primary outcome for the intensive control group. And in this case, this is just this amazing Kaplan-Meier curve that we don't see very often, right? In modern day America, in American medicine, a 25% improvement in the risk of the primary outcome with intensive blood pressure control. Right, there was no difference in the endpoint of serious adverse events. There were some more adverse events, including lower blood pressure, sort of non-orthostatic, some syncope, it's true, some acute kidney injury, and electrolyte abnormalities, in particular hyperkalemia. However, these did not translate into an influence on the primary outcome or when looking at any of the individual outcomes separately. So it is important to counsel patients, if you're going to choose a lower blood pressure target, about the potential incidence of these things, to watch out for them. But again, they don't seem to influence the quote hard outcomes that many patients, most patients, and doctors care about. Okay. However, importantly, blood pressures were measured in SPRINT in a manner that is not reflective of most busy primary care practices. So let's have a little bit digression to talk about measurement of blood pressure for a few minutes. So the reason why I think, again, it's an important time to digress is that when you present the SPRINT data, the question arises immediately of, well, gosh, that's a profound finding. Why don't we target blood pressure of less than 120 in all of our patients? Because that was an amazing finding, right? And I think the reason is, if you read the fine print of the SPRINT trial, and if you read the fine print of the 2017 ACC/AHA guidelines, you'll find that the reason that the guidelines have not recommended this low target is a recognition that how the blood pressure was checked in that trial was not like we do it usually, right? In the SPRINT trial, blood pressures were obtained using a technique called automated office blood pressure, AOBP. They use devices called the Omron 907XL device, which is a cuff that you put on a patient. The medical assistant pushes the button and walks out of the room. And then the cuff waits 5 minutes. It then takes 3 blood pressures spaced a minute apart and averages them. Right? So obviously this is not what most practices are doing. I know in our primary care practices through University of Washington, we're doing sort of second blood pressures and using that second blood pressure if it's lower, which I think is a way to try to get a little bit more at this. And I think we can use some other techniques that are important to use to try to at least imitate what was done in SPRINT and to try to get to perhaps a more representative blood pressure. So the first point is that, we really should be averaging 2 or more blood pressures ideally. An appropriate size cuff should be used. So it's a pretty simple indicator on the cuff itself. Patients should avoid caffeine, exercise, and smoking for half an hour prior to measurement. I mean, no one should be smoking, but if they are, to not smoke at least 30 minutes prior. The most important factor, in my opinion, is that patients need to have an adequate time to relax in a quiet room before checking their blood pressure, right? We all know our patients are running late. They run in off the elevator, their heart is beating at 120 and their blood pressure is high, right? Is that representative of their 24-hour average blood pressure? The answer is usually no. Patients should be seated in a chair with the back supported, both feet on the floor, and their arms supported at heart level, right? So what happens if you don't do all this stuff? Well, there's been a lot of data to look at each one of these blood pressure measurement elements. If you don't do them, you can get a artifactually high blood pressure by a dramatic degree, right? So talking, or even active listening while the blood pressure is being checked, the blood pressure can be high by 10, right? A distended bladder, really got to pee, it could be high by 15/10, right? The cuff over the clothing, right? This is a common thing that, we have to work with the medical assistants and nurses around. Wrong size cuff, smoking, back unsupported. This is something that people don't sort of remember. So you shouldn't be checking the blood pressure on the exam table. Patients shouldn't be checking their blood pressure at home while sitting on bed. It should be in a chair with the back supported. And then, having the arm dangling down, particularly while they're standing, can result in an artifactually high blood pressure. So, another way to get around these sort of artifactual office blood pressure features is to try to get patients to check blood pressures at home. They have to use the same technique that we use in the office, but there have been a variety of studies that have shown that the risk prediction is probably better, if done correctly, to have patients check their blood pressures at home. It can help identify white coat hypertension, masked hypertension, which is the opposite of white coat hypertension. We won't spend time getting into these today. Similarly, getting multiple blood pressures throughout the day can try to reveal, patterns of blood pressure if there's particular periods when blood pressure is high versus not high. And then, an advanced technique would be to try to help the clinician time blood pressure medications based on periods when the blood pressure is high. And just to kind of encapsulate this, there has been a lot more focus in recent clinical practice guidelines, and this is from the 2017 guideline, about using out-of-office blood pressures, right? This states that we should use out-of-office blood pressure measurements to confirm the diagnosis of hypertension and actually for titration of blood pressure lowering medications. Sort of the gold standard or the extreme version of out-of-office blood pressure would be ambulatory blood pressure monitoring, okay? Otherwise known as ABPM. So this is a device about the size of a smartphone, which connects to a blood pressure cuff, and it's worn for anywhere from 24 to 72 hours by patients. They do not have to push any buttons to get the device to check their blood pressure, and is usually set to check blood pressures every 20 to 30 minutes during the day and every 30 to 60 minutes at night. It can give you a remarkable amount of data as demonstrated in this chart below, which is kind of what the data is that you get, that can show peaks and valleys. And it also gives you average daytime and average nighttime blood pressures and a 24-hour average, right? This is the gold standard, can demonstrate the presence or absence of masked and white coat hypertension, and can also show diurnal variations, right? Now, what do you do with ABPM data, however, in terms of targets? Well, I'll say that people don't know for sure, right? No major blood pressure randomized trial has used ABPM as the exposure of interest. But there have been studies that have looked at, well, if you have an ABPM showing an average blood pressure of X, it's approximately equivalent to a office blood pressure of Y, okay? And so in general, if you're targeting an office blood pressure of, say, 130/80, that's here in the second row, that's about equivalent to a 24-hour ambulatory blood pressure of 125/75. Okay, so that's kind of about how that works. And the reason for that is that we know that there's a nocturnal dipping in most patients, where blood pressure goes down by somewhere between 10 and 20% overnight. All right, so we've talked about his target blood pressure. I haven't given you an exact answer for what his blood pressure should be. I think most people would say it should be at least less than 130/80, based on the most recent ACC/AHA guidelines. I will tell you now, kind of off the record, that in the fourth quarter of this year, the nephrology clinical practice guideline from an organization called KDIGO will be published that will almost certainly say that for patients with chronic kidney disease, we should target blood pressures of less than 120/80, right? So that may represent an additional paradigm shift for all of us. All right, so in the last 15 to 20 minutes, what workup should he have for his hypertension? So, the question is, should he be screened for some secondary forms of hypertension? This is what the clinical practice guideline says. It says we should screen when there are some clinical indications or exam findings, or in patients with resistant hypertension, right? And that is generally what I do, okay? So there are clinical clues suggestive of secondary hypertension, and that's what I'll go over here. So the first is this sort of severe or resistant hypertension. So most people would say severe is sort of over 160/110. That should trigger at least some form of a secondary workup. Resistant hypertension, I've already given you the definition. And in general, that should trigger, I think, at least some consideration of a secondary workup. Others may include hypertension in a non-obese young person, like less than age 30. Certainly hypertension associated with classic electrolyte abnormalities like hypokalemia and metabolic alkalosis. That's an error there on my slide. And then diastolic hypertension in older adults should also trigger consideration of a secondary workup, because the normal blood pressure in an older person is to have a wide pulse pressure, so a low diastolic blood pressure rate. So we're not going to go over all these today. We could do a whole talk in secondary hypertension, but these are some of the things that should be running through your head. So the two most common causes of secondary hypertension are hyperaldosteronism and renal artery stenosis. Primary kidney disease is there as well, although most people in this day and age are going to have had some baseline screening for CKD, either a basic metabolic panel or urinalysis. Less common forms include Cushing's syndrome in young people and aortic coarctation, which would be found generally by unequal blood pressures in a leg and an arm. Pheochromocytoma, which would be like the most frequently tested for, least commonly seen disease on the list. Sleep apnea, thyroid diseases, and parathyroid diseases, which I put in brackets because I think they are contributors to poor blood pressure control, but generally don't give someone resistant hypertension in and of itself. And then I've mentioned these sort of distal inherited monogenic conditions, which we're not going to cover. We're just going to briefly discuss these top two as they're what you're going to see most frequently. So hyperaldosteronism has been estimated to be responsible for up to 5 to 13% of hypertension in adults. Kind of a surprise to people who most people feel like it's probably less common than that. It does include people with both bilateral adrenal hyperplasia, as well as the sort of classic, what's referred to as Conn syndrome, which is an aldosterone-producing adenoma. The clinical features are hypertension, hypokalemia, and metabolic alkalosis, with the caveat that only a minority of patients actually have hypokalemia and metabolic alkalosis. So that is why I think it is worth your while in a patient with resistant hypertension doing the screening test, which is a morning aldosterone and renin ratio. I personally screen everyone with resistant hypertension and anyone with hypertension or spontaneous and minimally provoked hypokalemia for this disease. So renal artery stenosis, I've just laid out a few principles of testing here. So first of all, how does this work? Well, the idea is that a stenosis in a renal artery would make the kidney feel like the blood pressure is low, right? It's ischemic. That triggers renin release, which then activates the whole RAS pathway, leads to high aldosterone release, and hypertension through the action of aldosterone and angiotensin II. There are two general causes. One, by far the most common, is atherosclerotic disease. And then a much less common form, fibromuscular disease, generally found in younger people, typically young women. That is the major sort of demographic indicator of fibromuscular disease. Other clinical indicators of renal artery stenosis would be a relatively sudden onset of hypertension in a sort of older person, a high renin and high aldosterone state, so so-called secondary hyperaldosteronism. Patients who end up having acute kidney injury with hypertension treatment, not just ACE inhibitors and ARBs, but any blood pressure lowering therapy. And then classically, patients who have sort of a flash pulmonary edema with high blood pressure. The principle is you must be prepared to intervene if you find a positive test. Otherwise, why are we looking? And we'll go over that in a few minutes. Testing is really center dependent. So here at the University of Washington, where we're blessed with excellent vascular labs at both Harborview and UW-MC, as well as Northwest Hospital, I think a renal artery duplex that spares people radiation is a reasonable approach. In the community, I tend to recommend CT angiography because it is less operator dependent and has a high sensitivity. So what workup did I do for Dr. W? Well, I did a renin and aldo level, which showed not primary hyperaldo, but a secondary hyperaldo, so high renin and high aldo with a normal ratio. I did do a renal artery duplex for this patient because he was such a vasculopath and had relatively sudden onset of hypertension that was very severe late in his life. This showed bilateral renal artery stenosis. A follow-up cross-sectional imaging with an MR angiogram showed a high-grade bilateral renal artery stenosis. I did refer this patient to interventional radiology for bilateral renal artery stenting. He had an amazing response. Within a week post-procedure, he was down to 2 medications with controlled blood pressure. Now, this should not be the message for everyone that we should go looking and stent everyone with renal artery stenosis. And the reason for this is we actually know from a couple of large clinical trials, the last published in 2014 in the New England Journal called the CORAL trial, which is the figure I've shown here, that randomized patients with renal artery stenosis to stenting or to medical therapy alone with medications. And this, unlike the SPRINT trial, is the most common Kaplan-Meier curve in medicine, right, which is sort of superimposed, no significant benefit from the intervention. And so most patients with renal artery stenosis should not be stented. I still do refer some patients for stenting, and this is my list, sort of expert opinion. So recent onset of hypertension, someone with like a truly refractory hypertension showing up in the ER on 4, 5, 6 medications, someone with kidney injury associated with hypertension or its treatment, and those patients who have very proximal lesions with good-looking kidney parenchyma should at least be considered. And this is something I would do in consultation with cardiology, with me, or with vascular surgery. The final point in the last 5 to 10 minutes, what should his optimal blood pressure regimen be? So, the first point is to remember non-pharmacologic therapies. These are important. They are therapies just like medicines that can have real blood pressure impacts. So weight reduction by even 10 pounds can achieve a blood pressure reduction of 5, 10, even greater in terms of millimeters of mercury of systolic blood pressure. The DASH diet, which we all learn about and know, decades old now, works. Right? It works to reduce blood pressure. Sodium reduction probably works less well than the DASH diet actually, but does work. physical activity, even without blood pressure reduction, even without weight loss, can result in blood pressure reduction. And then moderation of alcohol consumption, while not a giant effect, does have a small effect. What about medications? Okay, so this is really just a summary slide that presents a summary of pages and pages and pages of the clinical practice guideline, these are your first line medications. Thiazide diuretics, a dihydropyridine calcium channel blocker like amlodipine or nifedipine, an ACE inhibitor or an ARB. ACEs and ARBs should not be used together, but one of these medicines, absent a compelling indication for something else, should be your first line treatment for a patient with hypertension. Okay. What about the question of choosing one versus a combination approach in initial treatment? Okay. So I think this is what our clinical practice guideline says, which I think is reasonable, which is in patients who have stage 2 hypertension, so over 140/90, that is sustained, given what we know about a blood pressure lowering effect of monotherapy, you're probably safe to choose 2 blood pressure medicines at the same time that are complementary. Okay. If a patient is in that stage 1 range, 120 to 130, then choosing one agent is reasonable. Now, this isn't a mandate. It's okay to go more slowly than that, even in patients with higher blood pressure, but this is the recommendation that is out there. There are compelling indications for certain blood pressure medications, and I think the ones to just remember, of course, are patients who have either atherosclerotic coronary disease or heart failure who may benefit from a beta blocker sooner than would otherwise be indicated, right? In the most recent clinical practice guidelines, beta blockers are relegated to like 5th line therapy after the top 3 plus spironolactone, right? So you're not going to reach for carvedilol or metoprolol for blood pressure treatment without some other compelling indication for the vast majority of patients. For patients with resistant and refractory hypertension, I'm just going to skip through this because we've already talked about it. But looking in this red box here down at the bottom, this is also from the most recent clinical practice guideline, which says, if you've got a patient on 3 meds already and you need more, here are your options. First, maximize their diuretic regimen. If they're not already on the maximum dose of their thiazide, choose that. If they're on hydrochlorothiazide and you can get them on the more potent chlorthalidone, consider that. The next step would be to add a mineralocorticoid receptor antagonist. That's spironolactone or eplerenone. And I think this is wise. And then, a final recommendation would be in patients who have chronic kidney disease, who have a GFR of less than 30, consider switching that thiazide to actually a loop diuretic. The thiazides lose potency below a GFR of about 30. And I'm happy to consult with anyone in these patients with resistant hypertension. So what was Dr. W's regimen? Well, even after his renal artery stenting, he still did need to use a low sodium diet, exercise, and he was on 2 medications. Notice he's on carvedilol already for his coronary disease, not necessarily just for blood pressure management. So these are the key points today. Blood pressure regulation and development of hypertension are complex processes involving multiple systems. There really has been a paradigm shift in favor of lower blood pressure targets compared to just a few years ago. And I think hopefully I've shown you why. Secondary causes of hypertension are important to consider. And in terms of people with true resistant hypertension, this may represent a large proportion, like up to a quarter. And finally, what I haven't really shared in writing here, but there are a lot of resources available at University of Washington for consultation for your patients with resistant or suspected secondary cause. I'm happy to be a resource at the Hypertension Clinic at Harborview. The University of Washington Medical Center Kidney Clinic has expertise in resistant hypertension diagnosis and management as well, and then of course cardiology. So I think I can stop there. and happy to take any questions that people have.
Thank you so much. So folks, feel free, please use the QR code to fill out evaluations. And if you have any questions, please either put them in the chat or feel free to unmute yourself since we have a couple extra minutes. And while people are mulling over, I personally have a question for you. Do you, in folks who say they come in, you measure their blood pressure, they've rushed into clinic, it's elevated, and you repeat after a couple of minutes, is there any like clinical significance or anything we can take from whether or not that blood pressure drops quickly or if it's more slowly, like if we actually have to retake it at the end of the visit versus 10 minutes after? Is there any diagnostic value in that, or is that more just a result of how we took the blood pressure?
Yeah, I think it's a really good question. It's nuanced, and I think the answer is no one knows the answer to your question. What I would say, sort of like anecdotally, is that if you notice that people's blood pressure is coming down either a lot or kind of slowly over the course of a visit, you may want to really put the idea of whether this patient has a substantial white coat component, even without rushing into the office. Really consider trying to get that patient to do some out-of-office blood pressures, whether it's Bartell's or whether they purchase their own home blood pressure cuff. And if it really looks like it's really substantial, then trying to get them ambulatory blood pressure monitoring or, really having them use a blood pressure diary and using their home blood pressures rather than their clinic blood pressures. I mean, I have a number of patients who, I just throw out the clinic blood pressures. I don't even use them because they're just not representative.
Gotcha. Thank you. That was really helpful. Any other folks have any questions out there?
While people are mulling it over, I mean, I think the one question we sometimes get is, how do I get access to ambulatory blood pressure monitoring? Yeah. This is a challenging one. So, in hypertension clinic, we have a couple of monitors. The cardiologists have a couple of monitors. The problem is we don't have enough to offer ABPM right now as like a standalone service. So I welcome referrals for people with resistant hypertension or those who are very young and there's a suspicion of a secondary cause, but we don't have the capacity right now to just sort of like do ABPMs on everyone. I suspect that within the next 5 or 10 years, 5 years maybe, more and more primary care practices will sort of obtain these monitors and get training in how to use them. But I will acknowledge that it's a frustration and challenge right now to get regular access to ABPM. And a lot of this is due to reimbursement issues. Medicare doesn't have wide reimbursement indications for ABPM. They're expensive. They cost thousands of dollars. So, it's a work in progress.
Well, it doesn't look like there are any other questions. Thank you so much for that super helpful overview, and a reminder for everyone that Dr. Rivara is a resource for us for our patients who we have difficult time controlling their blood pressure. So thanks for joining us. Really appreciate it.
You're welcome. Thanks for having me.
All right, everyone, take care and have a great rest of your day.